Dr. Sogade, I already was introduced earlier. He is past chairman of the board of the ABC and great speaker and great friend, and he's also electrophysiologist. So you guys have enough from the electrophysiology today.
Okay. All right, good. All right. Thank you, Dr. Al-Shawi, for the invitation. Today, I'm just going to present to you some strategies to prevent atrial fibrillation and reduce disease progression. As has been mentioned by multiple speakers today, we know atrial fibrillation is the commonest arrhythmia leading to hospitalizations in the United States, and it's an emerging problem worldwide. And I will submit to you that approaches to maintain sinus rhythm and prevent AFib through early definitive treatment will stop disease progression and is also beneficial to our patients. When you look at why do we believe that, sorry, those are my conflicts. When you look at the mechanism of atrial fibrillation, this is a conceptual relationship between atrial fibrillation because we have young people, even in our own experience, as young as 17 years old, that you will have atrial fibrillation. And you know that when people develop atrial fibrillation at such a young age, it's most likely related to some genetically determined causes. And then there is a component of normal aging-related substrate that is very difficult to modify because fibrosis and other changes develop as one gets older. And then the burden of cardiovascular disease, many of the risk factors that have been discussed today, contribute another component of modifying the disease substrate that leads to the development of atrial fibrillation. But the arrhythmia itself causes structural changes in the heart, and we use the term atrial fibrillation begets atrial fibrillation, whereby the presence of atrial fibrillation leads to remodeling changes in the atrial myocardium and in the heart. And so if we could modify this area, the cardiovascular disease remodeling substrate and the AF-induced remodeling substrate, you can see we have a significant opportunity to impact the burden and progression of this disease. In the electrophysiology lab and in some of the other studies that have been done, you can see that there are scar changes that happen as one progresses from paroxysmal to persistent atrial fibrillation. And actually, one of the factors that has been shown that really correlates with high risk of stroke is the amount of scar formation that happens in the heart. As you see, as the scar formation increases, the stroke risk increases in parallel. And in the electrophysiology lab, we can do what we call voltage mapping, where we map the atrium in the normal sinus rhythm. The red represents more scar tissue, and the electrophysiologic changes that we see that correlates with the scar tissue as well. And why is this important? Why do we need to prevent development of AFib? What we know is that atrial fibrillation can be sometimes in about half of the patient is asymptomatic. So I think it's important for everyone to take a lifestyle that, especially if you have high cardiovascular risk factors for stroke formation, aggressive efforts will be made to prevent AFib because it can lead to strokes. And the reason why is that when you look at the data based on implanted devices, depending on your risk score, as short as 5 minutes of AFib has been associated with some neurologic changes. And the general trend in the trend study is that 5.5 hours of atrial fibrillation is enough in some patients to lead to a stroke. And I'll show you why that is so. When you look at this data here, if you have a very low risk score for AFib, let's say we're using the CHAD-VASc or CHAD score, you need to have a lot of atrial fibrillation to form a clot. If you have no stroke risk, you can be in atrial fibrillation and not form a clot. But if you have a lot of risk factors, you don't need a lot of AFib to form a clot. So a very low burden of atrial fibrillation can lead to stroke. And that's why when you look at the new guideline that was mentioned by Dr. Valentin today, a decision to anticoagulate somebody should not be based on the duration or the burden of AFib should not be based on whether it's paroxysmal or persistent. It should be based on what is that risk score. And also, why do we need to prevent AFib? We know that when somebody stays in sinus rhythm, they do better, they live longer. And this study was kind of controversial. I know it's very popular. People tend to assume that just if people in atrial fibrillation don't do anything about it, they'll be fine as long as you keep them anticoagulated. I submit to you, when you look at the subsequent analysis of the AFAM trial, this is a trial that looked at whether we just control the rate or we keep people in sinus rhythm. It showed in this study that sinus rhythm is better, especially if you leave people on the anticoagulant. But if you treat people with antiarrhythmic drugs or you use digitalis, you actually increase their mortality. So it's very important to attempt to keep people in sinus rhythm. So preventing atrial fibrillation will lead to improved survival. Also, we know that in the Athena study, this is a study on a drug called dronedarone. What we noticed in that study is that in people who took dronedarone and stayed in sinus rhythm compared to placebo, they have a lower stroke risk. All these were anticoagulated patients. They followed standard therapy. They all received the anticoagulant. So the presence of sinus rhythm is protective against strokes. And why is such? When you look at the data from the Homestead County, and some of these data, I think will be reported when the Cabana study is finally published as well, is that when you look at, sorry, I think this my slide shifted a bit, but this is just age over year and the incidence per 1,000 years. When you look at atrial people, men and women with atrial fibrillation compared to the general population, those with atrial fibrillation have a higher risk of dementia and neurocognitive changes that happen just based on the presence of atrial fibrillation. And the reason why is that they are symptomatic and asymptomatic stroke, so that when you look at it, some of these changes may just be intermittent confusion and just not feeling right. And these are not full-blown strokes that you will expect. And the mechanism for that is that the presence of AFib creates a smoke that we see on echocardiogram or TE sometimes, that is more like a microembolic phenomenon, and also leads to hypercoagulability and chronic inflammatory state. And the presence of comorbid conditions increases this risk as well. And so what are some of the possible approaches? There are certain antiarrhythmic drugs that are safer than others, so some of those may be useful. Other non-antiarrhythmic drugs, treatment of hypertension is very important. And some of these approaches, as was discussed earlier today, have not been effective. And some of these have been discussed earlier, and some of these approaches, what I will spend the rest of the time to discuss. When you look on a population basis, if we want to really prevent AFib, we talked a lot about lifestyle modification, whereby you can help a lot of people in the general population by adopting healthy lifestyle, reducing tobacco, increasing exercise, salt diet, and avoiding excessive alcohol consumption, and managing cardiovascular disease aggressively will help. So we'll talk a little bit about what are those modifiable risk factors. The one I will focus on will be alcohol. I think it's going to be in the NEO prevention guideline. We know that about more than 50% of Americans drink alcohol regularly, and we know that the alcohol creates the holiday heart syndrome as an acute effect of excessive consumption of alcohol. But if you drink more than 21 drinks a week, your AFib risk increases by 39%. And if you drink more than 35 drinks per week, you increase by almost 45%. In women, more than 2 drinks per day increase the risk by 60%. So each additional drink per day increases the risk of AFib by 8% in both men and women. Also, the issue of physical activity has been discussed a lot today, but we know that low to moderate intensity physical activity like walking and bicycling will help to reduce atrial fibrillation. But what is actually important is that it's not just the physical activity, it's the cardiorespiratory fitness That is when you get on a treadmill, when do you get short of breath? How long can you stay on? Because one does physical activity by itself is not enough, but to improve cardiorespiratory fitness has been shown to be a more important factor. And like I shown that it's also possible to exercise too much, that the impact of exercise is a J-curve phenomenon. Many of us do not fall into this category, but most people stay around there. But you can see in women, there was no demonstration of a J-curve phenomenon in women, but it's seen in men who exercise high intensity exercise more than 5 hours a week. And physical activity and cardiorespiratory fitness, CRF is a marker of health status, and there's a linear correlation with development of atrial fibrillation. And if exercise program that is designed and tailored to improve cardiorespiratory fitness has been shown to reduce atrial fibrillation. And this is the CardioFit trial. I know there's been a lot of questions about the role of exercise today. In the CardioFit trial, this is a supervised prescribed exercise program whereby there were adjustments for patients' age. The exercise is tailored to the age and physical status. And other risk factors were addressed, including body weight, glucose control, diet control. That for each 2-month increase, greater than 2-month increase in cardiorespiratory fitness, you reduce atrial fibrillation burden. And smoking has been shown to be one of the leading cause of preventable death worldwide. And there is a 51% higher risk for atrial fibrillation in current and former smokers. And if one stops smoking, the risk is reduced. The next question is the area of psychosocial factors. I know that has been brought up a lot, and I think it's going to be addressed in the prevention guideline, but there is a phenomenon called trait anger. That is when you just very easily provoke, get angry very easily. Trait anger contributes about 10% is risk to atrial fibrillation development, feeling of hostility, and symptoms of anger. So to reduce atrial fibrillation, if you stay happier, it's protective. So in terms of cardiovascular risk factors, a lot of them talk about obesity and overweight and high blood pressure and diabetes today. What has been mentioned is that about 50% of the US population, adult population, are obese or overweight, and the AFib risk increases by 49%, and there's a linear correlation with BMI increase. And the AF increases by 48%. As Dr. Alshao showed in some of his slides today, actually what is important is the epicardial adipose tissue, which deposits around the atrium and also around the pulmonary veins. And this leads to some inflammatory and structural changes to the atrium that leads to development of AFib. And we know that in people who have extreme obesity, bariatric surgery reduces the risk of AFib by more than 30%. So losing weight generally will help everybody who is overweight or obese. And the role of hypertension has been discussed. What I'll just point here is that for every 10-millimeter increase in systolic blood pressure, risk for atrial fibrillation increases by 1.1 times. But what is also important is, as a question was asked yesterday about, people with low blood pressure, high blood pressure, but we actually think that the pulse pressure is also important because that's a marker of elasticity. And for every 20-millimeter increase in pulse pressure, AFib increases by 26%. Treating obstructive sleep apnea is important. It will reduce your AFib risk. And managing diabetes also will improve your AFib risk because 1% increase in HbA1c increases AFib risk by 13%, but aggressive management of diabetes has not been shown to significantly reduce AFib burden. And the role of cardiovascular disease has been talked about. In the new guideline, you can actually offer patients ablation therapy to reduce their chance of progression of congestive heart failure and to improve their survival by offering them ablation therapy early. Because about 1/3 of people with CHF will develop AFib. AFib will happen in about, heart failure will happen in about 1/3 of AFib patients. And then we talk about the role of genomics today, but what is important here is that when you look at all these factors, the genomics, proteomics, and metabolomics affect how drugs are metabolized and the impact of the environment on the gene. And you can modify some of these by adopting a very healthy lifestyle. This has been shown in people with low AFib, and it's occurs in younger patients. And what we know, why it's important to adopt this, is that we've known this lesson from coronary artery disease, that adherence to a healthy lifestyle has been shown to reduce coronary events by 50%, and it's putative that healthy lifestyle will reduce your AFib as well. I show this here because a lot of people place Holter monitors, and you always get these Holter monitors that you will see 5 to 6 beats of repetitive atrial tachycardia. What most people will do is that, oh, those are not significant arrhythmias, just blow it out. But what this study showed is that for people who have these short runs of repetitive atrial tachycardia or short runs of SVT, you may get the Holter report. They had 286 episodes in 24 hours, but they all last about 4 to 6 beats at each time. What has been shown is that those who have a regular SVT, that the P waves is not discernible, they have a higher risk of stroke and subsequent development of atrial fibrillation. And that's what this graph shows here. And then the other question is that when we ablate people, I know Dr. Fontaine talked about the Cabana study, we can actually change the natural history of atrial fibrillation. Therefore, when you look at people who got ablated and those who were treated with medication, the people who got ablated, their risk is almost normalized like those who never had AFib. And so why this is important is that if you imagine somebody who is 55 years old today, and is a man, has no hypertension, no diabetes, and you ablate them and they are free of atrial fibrillation for 5 to 6 months, and their chart VASC is 0, you essentially will stop the anticoagulation because they do not have AFib. And now they get to 65, they develop hypertension and diabetes, but they don't have AFib. What do? They don't have AFib. You have changed their natural history. And I think it's very important that we should treat these patients very early and offer them a more definitive therapy. And that's how you can actually change disease progression and alter the time course of treatment for people. And Dr. Gillespie talked about that yesterday. And in summary, AFib results as a consequence of certain genetic and structural disease states, and early treatment of predisposing conditions may alter time development of AFib. And stroke prevention strategies remain a critical part of AFib management. And use of NOACs, I think by the new guidelines, should be the mainstay. And in people who cannot take NOACs, warfarin is an alternative. And catheter ablation for AFib may alter time course of AFib development and progression. And the main body of evidence supports superiority of catheter ablation over antiarrhythmic drugs at this time. Thank you.